السلام عليكم. نحن مش سامعينك. انميوت دكتور. دكتور محمد.
الو.
اهلا وسهلا دكتور محمد، السلام عليكم. السلام عليكم.
الو دكتور مازن، حضرتك سامعني كده؟
ايوه نعم. اهلا وسهلا.
تمام. اهلا بحضرتك، ازيكم، اخباركم ايه؟
ازيك؟ والله
الحمد
مشتاقين
لله
جدا.
والله. ربنا يبارك فيك، تسلم، ربنا يبارك في حضرتك. هو النهارده ان شاء
الله
الله
يحفظك.
بزال ميعاد كمان 5 دقايق، مش كده؟
يعني 5 دقائق نبدا ان شاء
تمام.
الله.
ممتاز، خلاص ان شاء الله باذن
جزاك
الله.
الله خير.
اخبار حضرتك ايه؟
والله بخير الحمد لله.
معلش، انت عارف حضرتك احنا عشان في وسط الاسبوع، فانا يعني مخلص حالا الشغل، وغالبا هيندهوني تاني، فان شاء الله لا، ان شاء الله باذن الله.
تسلم، الله يجزيك الخير
ربنا يبارك
لحضورك.
في حضرتك. ربنا يبارك في حضرتك، وحشنا.
مساء الخير دكتور
تسلم ان شاء
محمد.
الله يا رب.
دكتور مازن، مساء الخير.
مساء
اهلا وسهلا
النور،
دكتور
اهلا
نانسي.
وسهلا، ازي حضرتك دكتوره نانسي؟
الحمد لله الحمد لله، زيك؟
كله زي الفل والله، كل سنه وحضرتك طيبه.
وانت طيب يا رب.
الله يخليك.
شو المناسبه؟ انا ما كثير متابع للفيسبوك بالمناسبه. ها.
ولا انا. بمناسبة
الحقيقه
انا قاعد في السوشيال
بالنسبه
ميديا
إن...
يعني. اهم
لا
حاجه
والله
يعني.
ابدا. بمناسبه بدايات العام الدراسي.
طيب كويس.
معك حق. الحمد لله.
احنا عندنا الدنيا مقلوبه في الجامعه، يعني عمالين نستعد بشتى الطرق.
اكيد. بعدين هلا يعني going back شوي to real education يعني.
يس ات از ريل اديوكيشن،
والله.
خلاص بطلنا الاونلاين تماما، كله بقى رجعنا تاني زي ما كنا.
طيب يلا، الف
الحمد
مبروك.
لله.
هاي يعني
الله يبارك في عدد.
انتم طيبين، مزبوط يعني، الف مبروك. احنا how we have just 3 minutes. Yes.
yes.
Christopher, do I think he's still in Russia?
اوكي. لا I don't think I think لا المؤتمر خلص متهيألي.
خلاص.
متهيألي everyone is traveling to Amsterdam النهارده المفروض يعني.
You're not going دكتور محمد؟
للأسف I was going، بس الحقيقة يعني عندي ارتباطات هنا فمش قادر أروح.
سيم، انا يعني استسلمت، قلت خلاص ما حروح. يعني حنشوف اونلاين وخلاص، واحد مرتاح وقاعد وبيشتغل لسه يعني الهمه ما رجعت مثل الاول.
معك حق.
لا والله، ده أنا حتى عندي يعني I have dues هناك، المفروض إن أنا هقولها مش في المؤتمر نفسه، في ساتلايت ميتينجز كده حوالين المؤتمر، إنما للأسف ما قدرتش خالص إن أنا أفلفص زي ما إحنا بيقول.
هو حضرتك دكتور محمد راكب في مرجيحه دلوقتي؟ لانه يعني دخنا نحن بنتابعك.
لا ده
الصورة
الموبايل
رايحة
بس،
جاية رايحة جاية.
الموبايل عشان بس بالموبايل مش بالكمبيوتر النهارده.
We have friends from everywhere ما شاء الله. Jesus, our friend from Mexico, saying good morning. Maybe after 1 hour, Jesus will tell you good night. MashaAllah, Mariano from Guatemala. Perfect. Alhamdulillah. Farah from Qatar. Most welcome, everybody. I'm really happy that Sinjab Academy can gather people from everywhere, from all countries, just for science. That's very nice. From Iran, Mr. Sayed. Very nice. Most welcome. Christopher.
You joined, yeah.
Hello.
Hello. Nice
Lucky,
to
yeah.
see you again.
I just got back from Russia.
So you are in the UK now.
Yes.
Great. Thank you for joining us.
Yeah, thank you.
Pleasure. Nice to see you all.
Nice to see you.
So I think this session will be very distinguished. Thank you very much.
Yeah.
So Nancy, I think your heart is beating now.
Actually, yes. Yeah, just arrived home and I'm a little bit, my slides are just shuffled a little bit. So, but I have Christopher Liu and Mohammed Hasni here. So I think my backup is guaranteed, yeah. So shall I share my screen?
Yes, please, try.
Uh,
You can.
yeah, I can.
By the way, the views of the last lecture, which was the peripheral, the PUK, okay, the views on the YouTube channel, I think now more than 800. More than that, maybe reached the number 1,000. I'm not sure, but around this number. Okay, so let us start. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everybody, and good morning, good afternoon, good evening, wherever you are. And you are most welcome to this session number 8 in the Cornea series of the Sinjab Academy. And today, I'm very delighted that we have the eminent speaker, Dr. Nancy, and the eminent panelists together with us, Professor Mohammed Husni and Professor Christopher Liu. So I'm sure that this session will be spicy and very rich and informative. Please, Nancy, the stage is yours.
Thank you very much. Okay, so as it's a very important topic, not only for ophthalmologists, also for anybody who is encountering emergency situations, whether in the ER, at home, or general ophthalmologists and young ophthalmologists and residents. And I hate chemistry, absolutely. It was one of the least favorite topics when I was in high school and university. And But sometimes you have to face your fears. So this lecture is about how you face a dreaded topic like chemical burns. Now, to start with, what is peculiar about the chemical burn? Apart from that, they stand as a different entity in eye disease. Treatment relies upon proper diagnosis, and time is very crucial in predicting the outcome. You don't want to miss a chemical burn because it's considered a horse of Troja, حصان طروادة for all eye doctors. We can classify chemical burns in the simplest form in order to know where you stand and how to act and manage these kind of injuries or assaults to the cornea or to the eye. And I prefer, there are so many classifications, I prefer this very simple classification system because it's easy to apply and easy to abide with. The Roper Hall classification, which says that grade 1 that has a good prognosis is associated with no limbal ischemia, so there's no blanching of the blood vessels around the cornea, and only epithelial damage is noticed in the cornea. Now, stage 2 is associated with also a good prognosis, and it is associated with less than 1/3 of the limbus being ischemic. And you see haze in the cornea, but the iris details are visible, and this is what you see in the second photo. The third stage is usually associated with guarded prognosis, and it represents between 1/3 to 1/2 of the limbus being ischemic and associated with total epithelial loss and haze that obscures iris detail that you cannot see through and iris details clearly. Stage 4 is a very dreaded and poor prognosis, and it involves more than half of the limbus involved. And usually the cornea is opaque, and the iris and the pupil, you cannot see them. Usually, sometimes if it's more complicated, it might be associated with ciliary shutdown, hypotony, cataract, and a lot of sequelae. Now, one of the very important things or steps in managing chemical burns is differentiating between an alkali and an acid. Put so simply, the alkali causes a more severe injury compared to the acid because it penetrates rapidly, it combines with the cell membrane, and this is very basic. It combines with cell membrane lipids, mucopolysaccharides, and collagen, resulting in disruption of cells and necrosis of the tissue. And the alkali injury is what we call saponification. It saponifies the cell membranes and the intracellular bridges, and this facilitates their penetration into the deeper layers and in aqueous and vitreous compartments. So it cuts through the tissue. It saponifies and cuts through the tissue, and that's why necrosis happens of the conjunctival blood vessels, and a cooked fish eye appearance is seen. Now, the acid, on the other hand, is less severe because the acid usually they denature proteins, and when they denature proteins, they cause or result in a coagulative effect. So as if they form a border for the extent of the injury, and it stops where it coagulates. And this is why we say that alkali burn cuts through the tissue, while acid burn usually it stops at a certain point by forming a barrier. It's also important to know what common acid and alkali substances are present around us in the environment. Usually, it is what we encounter is usually domestic acids and burns, like hydrofluoric acid, which is weak and usually present in rust remover and glass cleaners and something like that. The more severe is present in sulfuric acid, which is present in car batteries, fertilizers, and explosive dyes. It's a very severe kind of acid. And there's the nitric acid, which is also a strong acid present in fertilizers and explosives, rocket propellants, and this is not usually something that we encounter in our clinics. And it's usually present in production factories, and so usually in farms or associated in factories, the kind of acid that causes injury and they come with it is the nitric acid. Chromic acid is a strong acid also, and but causes an intermediate. It is used as an intermediate in electroplating ceramic glazes and wood preservatives. So it's all used in the industry. It's all around us, and in any kind of chemical injury, regardless what the causative agent is. It's very important to deal with it as a top emergency and not to defer acting upon it. How do they present? How would a patient with a chemical injury present? They would present with a wide spectrum of presentation, and the spectrum presentation depends on what inciting incident or what inciting factor has been encountered, and what's the severity of the agent that's been involved in the injury, and also the presentation depends on the severity of the injury and how strong is the chemical agent that has been involved. For example, let's say a patient would come because of the domestic encounter with an acidic used in at the house for cleaning ovens, for example, would come not immediately. They would come after a few hours, next day or third day, because the redness and the itching and the grittiness wouldn't go away. They wouldn't come immediately, but a person who would come with an explosive of a car battery would have more elements of injury that would come and rush to ER immediately, and the chemical injury would be concomitant with the initial presentation because there would be burns on the face or wounds because of the mechanical impact. Patients would come with watering eye, red eye, pain, vision loss if there's associated severe involvement of the chemical agent, white eye or white cornea if there's blanching of the cornea in severe ischemia, or sometimes soft eye if there has been a perforation or a ciliary shutdown because the eye has been so severely damaged. There's a photophobia, of course. As you said, pain and photophobia is one also of the, and the grittiness, gritty sensation if it's only an epithelial loss. Now, one of the fundamental of managing a chemical injury is 4 or 5 points. Regardless of what is exactly the chemical that is involved, there are common goals of management. And these include, first, you have to remove the offending agent. As long as the offending agent is in the vicinity of the eye, whether it's an alkali to a greater extent or an acid to a lesser extent, the damage will be ongoing. The second thing, we want to promote the surface healing and the reepithelialization of the cornea. The third thing would be to control the inflammation that is associated with such an injury. And fourth, we want to prevent infection because the surface layer of the eye has been violated and it is compromised and all opportunistic infections are there to cut through. And fifth is to control intraocular pressure, especially if the alkali has cut through to the trabecular meshwork. And the sixth is managing the sequelae of the chemical injury, which is the complications that might accompany it. So what shall you do? You are in the ER or in the clinic and a patient comes to you with a red watery eye and talks about an incident of something chemical, not sure what it is, getting into the eye. Sometimes it's in the young or the housewives or usually industrial, so we're talking about young males. They come with a different presentation, as I discussed, and it's important before you just go through the history or do anything, the word a chemical agent should alert you to go and bring a washing solution, preferably distilled water, tap water, if it's clean, if you guarantee if it's clean, any isotonic solution, sometimes hypotonic solutions can be also used to just copiously irrigate the eye. Wherever you are, just defer talking to the patient and try as much as possible to run clear fluid into the eye, at least for 15 to 20 minutes. Now, we're not talking about bringing syringes and just irrigating the eye. It's important to bring like 500 cc of at least of fluid and just washing the eye with it for at least, as we said, 20 to 50 minutes. And it's very important at this stage to, especially if it was a child, to double elevate the eyelid, to check if there are some like cement, something that's stuck under the eyelid that would cause a problem if you did not clear it out, because you don't want to put yourself in that vicinity of missing something like that, especially a cement or a alkali agent. There are two ways of to document that you're already cleared all the inciting chemical or damaging chemical from the eye. You can use litmus paper or whatever pH detector to check that you have neutralized the acidity or the pH of the cul-de-sac or the eye. If that is not possible, you just can make sure that you copiously irrigate for a long time under the eyelid and remove any particles that are around, and take the patient to the slit lamp and check again and again that you have made the proper irrigation and washing. And then you can just sit with the patient and start your chair time. You can take history. You can take history while you're irrigating the eye, or you can just take history after you finish the irrigation and starting to examine the patient on the slit and talk to him or his family or whoever companion is bringing him about what kind of injury, when did it happen, what kind of chemical agent that was involved. And this gives you just info of how aggressive you should be about treating this patient. Because if it's an acid, then you might be a little bit assured. If it's an alkali, you have to triple check the eye that you have removed all the affecting chemical. Okay, so you're in your office or in the ER, a resident or an ER doctor, and you want to start prescribing drops. It's very important to start prescribing drops or instilling drops immediately. You don't need to wait to refer the patient to a cornea clinic next day or the day after when the referrals are scheduled, because this is a top emergency. And as soon as you start treatment, you're saving the patient's eye and absolutely his life. So you need to start with hourly Rubicon drops to facilitate healing. And whatever drops I'm talking about, it's preferable to be preservative-free. You want to start steroid drops, even if there is an epithelial defect, as soon as possible. And you start with a potent steroid like Pret Forte hourly, and then you taper it a little bit, at least for the first 7 days. And this is one of the very infrequent situations where you need to start drops. Steroid drops, even if there is an epithelial defect in the eye, because you are more concerned of stopping the inflammatory response rather than the healing that will be completed soon. So in favor of the steroid drops, the only time that you need to stop the steroid drops is between 10 to 14 days when you see that it's not, the inflammation is subsiding, but the defect is not healing. In order to boost epithelial healing, you might add vitamin C at a dose of 500 milligram 3 times daily, and an anticollagenase like the doxycycline and tetracycline, which helps the buildup of collagen by inhibiting the collagenase enzymes in the cornea. Antibiotics are added because you want to prevent infection that might cut through and take opportunity of the open violated epithelium. Sometimes these patients come with glaucoma or a hidden glaucoma or a risk for glaucoma, so you might need to add preservative-free, preferably anti-glaucoma agents. And then this is, as a first-line treatment, this is what you have to do. Second-line treatment, you refer him to a more specialized clinic where we might think of amniotic membrane in the first week in cases of extensive damage, or once epithelialization and scarring has occurred and the eye is in the scarring stage, then we think of other kind of surgeries to restore the vision. Now, what about managing the sequelae of chemical burns? And let's talk about this. So the most important thing for the general and the young to know what kind of drops and when to kick it in. And this is very important because the sequelae that the patient would come with would stop at a certain stage, rather than, let's suppose, instead of the patient being referred to a cornea clinic with stage 4, which is very, very poor, the patient might come with a stage to, for example, what has symblepharon, you want to, or opacity, but the eye is still preserved. So time is very crucial, and what you do at the first 48 hours and how you continue your treatment is very crucial, because believe me, once these patients, and they will all pour to the anterior segment clinic or the cornea service, once they pour in, it's very important which stage you refer them, because at a certain stage we can do a lot and restore everything as if it's nothing happened. But if they were missed or deferred for a longer time, they come with us with thesis, and at that time we do nothing to them. So they will be referred, but please refer them with a stage that's earlier than stage 4 anesthetic eyes. So what are options and garments we can use in the cases of a sequelae of a chemical burn? They would come with a limbal stem cell deficiency. If it's a deficiency that's more extensive, they might come with a vascularization, opacification, conjunctival overgrowth, loss of fornix, symblepharon, ankyloplepharon, corneal thinning, and perforation. These are the thinning and perforation is in a very latent stage, and we're talking about melting and perforation. Now, for the vascularization, we can deal with anti-VEGF therapy and cauterization, and we just can rehabilitate the cornea in order to receive a kind of transplant, whether it is a partial transplantation or a full thickness. And it's important to just rehabilitate the surface as much as possible before attempting to graft, because an angry vessel will definitely attack a new cornea. We might think of transplanting limbal stem cells if the other eye is still viable, and I'll be talking about this later in the subsequent slides. I'm just talking about an outline. The opacification can be treated also with replacing the cornea. The conjunctival overgrowth also can be pushed away. Fornix reconstruction is something that's absolutely doable, and with amniotic membrane, and you can use buccal mucus graft and reform the fornix, and the symblepharon and ankyloplepharon can be dealt with. It is the corneal thinning, as I said, and the perforation that's dreaded, and we sometimes we just avoid reaching this stage, because at that time, if the eye is aesthetic, we're just losing it. If it's not, we just save it by some amniotic membrane or cornea or partial tectonic grafts. Now, what are the other sequelae you have to deal with, or we have to deal with, is glaucoma. As I said, in alkali burns, if the offending agent just cuts through and reaches the angle, then glaucoma is inevitable, and you have to address that. Sometimes there might be a ciliary body shutdown, and the eye would go into hypotony if it's not salvageable, the trabecular meshwork. And sometimes because the inflammation, the fulminant that occurs might cut through the lens and cause cataract. In addition, that the initial injury might bombard the lens and cause cataract by mechanical affection.
So
okay, I like this chart a lot, and I put it in front of me every time I talk about limbal stem cell deficiency. And the hallmark of chemical injury is the limbal stem cell deficiency and how we deal with it. We can divide limbal stem cell deficiency into a partial deficiency or total or severe partial. Now, the partial limbal stem cell deficiency is usually something that all ophthalmologists can deal with, and we have two garments or two arms, either conservative management or surgical management. The conservative management we use when we are sure that there are enough stem cells to rehabilitate the cornea. So we boost the stem cells around the cornea by lubricating to enhance the reepithelialization. We give antibiotics, as I said, to prevent infection, the steroids also to enhance, to suppress inflammation, and sometimes autologous serum to kick in growth factors and rich materials that will help in proliferation of cells and the viability of the tissue. And these are things we use only when we are sure that there's more than half of the stem cells present and we're just boosting their effect. Now, if we lost most of the stem cells, these garments or these things, they do nothing. We're just wasting the time of the patient and your time. So sometimes in partial limb stem cell deficiency, we go to the surgical management, and we might do epitheliectomy or epithelial debridement, superficial keratectomy, and we might use an amniotic membrane transplantation, or sometimes combine superficial keratectomy with amniotic membrane. And why we use amniotic membrane is it's an avascular matrix. And it's important because it's an antifibroblast. It has a lot of nutrient-rich material that helps decreases scarring, promotes healing, and decreases the effect of and enhances the effect of reepithelialization. Now, when we have a severe partial, which means like more than half of the limbus is affected, or a total limbal stem cell deficiency, then we cannot wait for whatever topical treatment we need to kick in. And we go totally to surgical management once the eye is quiet. And these include a conjunctival limbal graft, whether it is allograft or autograft, a cultured or cultivated corneal epithelial cells, or keratolimbal allograft, and I'll be explaining this.
So, about our options, let's know first, how does the...
Okay, now what about the amniotic membrane? Now, how does it work? The amniotic membrane, as I said, it's a thick basement membrane with an avascular matrix, and it has no inflammatory response. So the reason we're using an amniotic membrane is to suppress the inflammation. So, and the scarring is kept at bay because it has an antifibroblast effect. The growth factors are supplied for progenitor cells, which means that we have a longer lifespan and a better differentiation, and it is a scaffold for epithelialization, because sometimes the epithelial cells, they just need at the palisades of Vogt or at the limbus, they just need some booster to enhance their movement. This is about autologous limbal stem cell transplantation. Usually what we do is that you don't take more than 4 clock hours from the other eye, and we don't need suppression. And if we take it from a living related donor, we need HLA typing and immune suppression. And they usually combine this with an amniotic membrane. Now, the amniotic membrane can be put in different ways, and you can see this in the 4 pictures. You can put it alone as a scaffold for epithelialization. This is if you have a partial defect. Now, you can put it as under the graft, or over the graft, or a sandwich technique between the autologous graft and the limbus, because it might act as a scaffold or as a cover to promote epithelialization and healing. So we cannot overestimate, but it's very valuable to have an amniotic membrane around. And it's very important if you can just liaise with if you don't have it ready, you can just liaise it with the gynecologist to obtain an amniotic membrane graft when there's a cesarean section, and you ask the fellows to bring it to theater, and it comes in no time. What about keratolimbal allograft or simple limbal epithelial transplantation? These are very simple way of obtaining a limbal epithelial transplantation or stem cells from a cadaveric cornea. And in these cases, we need usually immune suppression in order to maintain the viability of the tissue and these stem cells. The keratolimbal allograft, as you see, and here it's just you remove the conjunctiva from the corneoscleral disc from a donated cornea, and you obtain a little bit of the limbal stem cells or the limbus, and you cut it into 2 halves, or you can put it as a whole on the corneal limbus. I like to cut it into 2 halves and stitch it around with a tucking in method. The slit or simple limbal epithelial transplantation, you obtain the same strip of limbal stem cells, and you just slice it and dice it as small as you can, and you just put it on the cornea. You can glue it in place. You can put a contact lens over it and an amniotic membrane, and it starts proliferating in no time. And I actually prefer this simple limbal epithelial transplantation over the KLAL. And this is one of the uses of slit. You just cut the limbal stem cells and use it. You can put it in the limbus. You can put it as pieces over the cornea after debriding it. I use it with patients who have keratoprosthesis to enhance the limbal stem cells. Also, I use it for patients who I want to rehabilitate the cornea before I transplant a usual cornea. And starting the second or third day, you can see epithelial cells traveling away from these islands, and you can just monitor them and see how they work. And it's a very good tool. This is one of the, also it demonstrates how slit works. You can see the first one, this is a borrowed, actually, this is it's not my own photos. The first one, you can see the vascularization and the adhesions, and that has been removed and superficial keratectomy done. And then you can see these small dots of slit, limbal epithelial transplantation, and then this is one of the fibrovascular tissue that's growing onto the cornea, and then you give it some time to regain its transparency, and this is the end result of a simple limbal epithelial transplant. Now, this is an extreme case. Usually, unless you have a reservoir of simple of epithelial cells, you would get that transparent cornea, because slit alone does not give you that result, that wowing result. It just gives you something which is near to this slide, and it gives you the opportunity to transplant a cornea that is not under the danger of vascularization and rejection. The question is, how far would you go with surface reconstruction in a patient who underwent chemical injury or burn using stem cells without with corneal transplantation? And this is a gray zone. When would you tell the patient this is all you've got and there's no more to give or no more to go for? And when would you just keep going and trying? And the answer is, can the keratoprosthesis be a game changer in these patients? Now, the answer is, if it's used when needed, desperate cases with multiple comorbidities to bypass the ocular surface in the cornea, and if the complications are addressed and the expectations are explained, or the compliance is promised by the patient, and a commitment is applied, then yes, keratoprosthesis is your choice, and it can be a game changer and make a difference in the life of your patient. Because if you have tried everything and all the surface rehabilitation procedures, but the eye is still opaque, vascularized, and there's no role of using a cadaveric cornea for visual rehabilitation, of course, you cannot leave the patient, especially if young and dependent, or if there is a bilaterality in the chemical injury without a solution, keratoprosthesis comes on your way. Now, there are two kinds of keratoprosthesis, and it's very important to differentiate between candidates. There's the keratoprosthesis, which is most commonly used for the wet blinking eyes, and this is the Boston K-Pro. As you can see in the first slide, it's a device made from two plates, an anterior plate and a posterior plate, with a cornea of any quality that can be sandwiched in between and used to be sutured into the patient's own corneal rim. And this is how it looks in cross-section. And it's easy to assemble, and it's just you stitch it on the patient cornea like penetrating keratoplasty. If the patient has a very good wettability of the surface, if it's compliant with the drops, it has an excellent prognosis. If the posterior pole is intact and the patient does not have any other comorbidities, its problem is usually how you monitor the glaucoma, as in any kind of keratoprosthesis. Now, the other kind of prosthesis, and I'm talking in the presence of the master of keratoprosthesis, the OOKP, Dr. Christopher Liu, is the osteodontokeratoprosthesis. And this kind of prosthesis is fashioned from the patient's own tooth root, as you can see in the first photo. And this is in the second photo. Now, this is used in patients with a picture like this, a keratinized, dry, non-blinking eye. So if you see this picture, a matted, keratinized, non-blinking eye, the chance of accepting or retaining a keratoprosthesis like the Boston, is very, very small and humble. And the only chance of visual rehabilitation is performing an osteodontic keratoprosthesis, which is a very complicated surgery, and it needs a lot of commitment between doctor and patient. And simply put, it's a tooth root that you take from the tooth. You implant an optic in this tooth root, and after rehabilitating the surface with buccal mucous membrane and superficial keratectomy, and just waiting some time for the lamina, because this is a lamina, this is the artificial cornea. You just implant it. It's not just, you implant it on the cornea, on the patient's own cornea, with so many steps after decompartmentalizing his eye. And the retention rate for osteodontic keratoprosthesis, although it looks like so weird and complicated, is very high. It's like 85% in 15 years. And the visual potential is really that great if it is used in patients with good visual potential. As I said, it's the longest lasting. This is the end result, how the eye looks like in keratoprosthesis, although it is alien-like. And I also said the patients, it looks alien, but at least you can see. So it's for them to decide whether to look good or see well. And 75% of patients, they see 6/12 or better if the posterior pole is intact. I hope this just summed up what are the treatment options and how we deal with chemical injuries. And I'm very eager to learn from Dr. Lou and Dr. Hasni their feedback. And thank you.
Thank you very much, Dr. Nancy, for the nice presentation as usual. Now I open the stage for the discussion and for Professor Lou, Professor Hasni.
Dr. Nancy, that was a brilliant talk. Thank you very much. And it's succinct and to the point, and you've covered everything. May I accentuate a few points, Dr. Nancy?
Yes, please. Please do.
Okay, so let's have a look. I wanted to say that prevention is really important. Then we won't get into this mess because some of the injuries are so severe, especially if it's a chemical injury with a hot chemical under pressure. That can be just so awful. So I think, firstly, we have to encourage people to wear protective eyewear when they're doing work, whether it's workplace or whether it's DIY, doing cleaning or caustic soda, clearing drains. They really need to protect their eyes. And the other thing is regarding legal protection. So for each government, if they can pass law to protect workers, so they are made to wear protective eyewear, and also in very dangerous situations that the employers could actually be punished to a certain extent if they do not obey the rules. And I think we also need to educate the general public, possibly not just for protection, but some kind of culture change as well, because I know that in some cultures in the world, people go and punish their friends and spouse if they're very, very angry with them with an acid or an alkaline attack. And that is just so awful. I think we need to tell them that it could be, it's just so severe that it's just it's not acceptable, you know, from a humanity point of view. So the second point regarding irrigation, I do think this is very, very important, and it is the first thing that one should do after checking the pH. And I agree with you, copious irrigation, immediate copious irrigation, and rechecking the pH as well afterwards, because whilst it might regain neutrality, some of the alkaline material can leach out from the tissues again to make the environment alkaline, and more saponification can occur. And I also agree, so important to evert lids to look for particulate matter, because it just could be trapped there. And, you know, when you're in a rush, you might forget. And then the particulate matter continues to leach out some alkaline material. I also agree with you, the initial use of steroids, so important to cut down the inflammation. and the initial steroid should be very intense and very frequent. But later on, we need to ease off, otherwise we could then cause a corneal melt. Then my final point relate to stem cell treatment, and I think it's very important, as you've noted, to distinguish between partial and total, and also whether unilateral and bilateral. Because if it's unilateral, you have the opportunity to get some stem cells from the other eye. But even if it's unilateral, we cannot completely trust that it is unilateral, because sometimes when it's asymmetric, then the patient only remembers that one eye was damaged, and they don't remember that some also went into what they consider to be undamaged eye. And it is possible, when harvesting some stem cells from the good eye or the better eye, it can decompensate that eye as well. And also, as you say, you know, when there is dryness and lid defect, then stem cells may not work because the environment is so poor that the stem cells may not survive. So I think it's very good that you've mentioned doing bits of limbal corneas as a source of stem cells. Well, these are not true stem cells. They are the next layer down, so they're not as good as true stem cells, but they will do if you don't have more to offer, and also if you don't have recourse to high technology like ex vivo expanded stem cells, like we have in Europe, and you know, per treatment is about 80,000 euros. So that's not manageable by the far majority of people. And also, you know, thank you for mentioning sequential sectorial conjunctival epitheliectomy, as well as described by Professor Dua. If you still have a small area of stem cells, if you keep brushing off the conjunctival intrusion, then even a small area of working limbus can repopulate at least the central cornea, allowing the patient to see again. I congratulate you on an excellent lecture, and sorry for stating the obvious and making my comments. Please forgive me.
Thank you for the comments.
Yeah, thank you, Prof, for the excellent discussion and addition. Thank you very much. Professor Husni?
Yes, well, actually, I really learned a lot from this lecture. Thank you so much, Dr. Nancy, for this very comprehensive lecture. And thank you so much, Professor Liu, for these remarks. After the lecture and after these remarks, I have very, very little to say. I learned so much from you guys. I only have actually questions rather than remarks or comments. Now, we see this a lot, and this is honestly one of the things, or the branch of corneal surgery that I do not like, in spite of being a corneal surgeon. So this is something that really, when I see a patient, I wish that it went to another corneal specialist than myself. So I have, and the reason because of this is that we have so many cases of these guys, and sometimes the success is not as we hope. Now, just a couple of questions. I have done slats, I have done clets, I've done clouds, I've done all sorts of things. But the thing that I consistently have found is that allograft specimens from corneoscleral buttons that were actually prepared for a keratoplasty, and the cornea was taken out, and we use the rest of the limbus for this type of surgery. They do not work. They never work. And is this autografts do work, and sometimes are very beautiful. We get very beautiful.
Oops, I think we've lost
Professor
Hosni.
Muhammad, we cannot hear you.
I think the swing just cut the signal.
Yes.
So my
Dr. Husni,
question,
now,
and for Professor Liu.
yes, go on. Go on, please.
Let's go.
Maybe he will join us now. He will rejoin. Great.
I think the question would be, oh yeah, it is.
Prof. Husni.
Yes, do you hear me now?
Yes.
Yes.
I've
Good.
been talking for the past 20 minutes to myself, basically. So
Yeah.
so sorry about that. I think I'm driving and I went to a batch of bad signal. So I just wanted to ask. I don't know where did you reach in my question. I've been doing sleds and clouds and all sorts of limbal cell transplantation, but the consistent thing that I found is that the allografts from donors with prepared corneoscleral grafts for keratoplasty, when I take the rest of the grafts after the cornea is being cut off and I use it as a limbal transplant, they do not work. I have had very limited success with this type of surgery. So I just want to know the feedback from you guys. Is this the same? Nancy?
Should I go? Okay. As I said, it's not superb, but it worked in rehabilitating few cases where I acted very quickly, and the patient, they did not have complete limbal stem cell deficiency. So if I had a complete limbal stem cell deficiency and I use a slit, it's not that promising. Yeah, you are very right and correct. If I use the slit from a young donor, it surely acted better than if the donor was old. And what's the cause of death and who took it in the time of transplantation? Like if I took it from an imported cornea, is different than, because it takes like 5 days to get to us. It's different than when I take it from a cadaveric
totally agree, because here in Egypt we only get imported cornea.
That's why I think
get
because
very limited success with this type of surgery.
Hours, and I know this limbus is going to be used for a slit or a clow. They acted much better than when I used it from a cadaveric donor. And to tell you something, I had a girl who was like 5 years old, and she had a chemical injury. It's just with a domestic cleaning substance. And I did all the forensic reconstruction, amniotic membrane, all this stuff. And I did a slit, and she just failed like 2 weeks later. And I had to use a slit from a fresh cornea at the same time, 3 months later. And it's magic, because I transplanted her like recently with a fresh penetrating keratoplasty, because the surface just gained momentum in a very big difference compared to the imported cornea. So this might be the
okay.
reason.
So in this particular case, can I ask, was this a bilateral injury or a unilateral injury?
Unilateral. It was a unilateral.
Sorry?
And it was a unilateral.
Okay. So why didn't you plan to get something from the other eye?
Yeah, I did.
Okay.
She had the injury like at 3 years of age. Now she's 11. So I've been rehabilitating this eye since that time. And I did the 4 hours at the initial rehabilitating the eye, but it was so severe that they did nothing, the 4 hours from superior and inferior. And I did not want to compromise the other eye more. So I just relied on something.
Right. So my final question is, when you're doing something like that, do you do a lot of dressmaking and fashioning with a piece of paper on the damaged eye, and see how much of the limbus that you need, and then because this is what I was taught to do, and this is what I do until now. So, and I then take this piece of paper, put it on the other eye, and then fashion the same area or the same geography of the limbus that I need, and then put it back on. Does anyone still does that, or is it just me?
I don't do that. Not sure what Christopher you.
I think usually people say that the highest concentration of limbal stem cells are at the 12 and 6 o'clock position, and nobody really dares to take more than 2 or 3 clock hours. I mean, but nowadays we take a 1 millimeter sample and send that off for amplification, or send it to a specialist center, or we can also take that small sample and chop it up and sprinkle onto the cornea of the fellow eye, recognizing that it will not be as good as proper amplification ex vivo. But then, you know, we can only work with what we've got. Not everything is available everywhere, and not every patient can afford everything. So we can only do our best and avoid doing the things that we know won't work. That's all we can do.
Yeah, actually,
thank you so much, both of you, for all the information that I learned today.
Thank you, Professor Hasni. Thank you, Professor Liu, for highlighting this therapeutic choice, because lately we've been liaising with the stem cell center in university. We've got these, it's like there's a stem cell study ongoing, and they are in coordination with us to try cultivating the limbal stem cells for patients in need. And as you said, if it costs 80,000 euros in Europe, it costs 100,000 JDs per one cultivation in Jordan. But it is reserved for the very desperate cases, especially the unilateral, where we can take pieces of epithelium stem cells from the other eye, as you said, and it takes like 11 to 2 weeks to be cultivated. And it comes like on a sheet and it's transplanted, and it gives much more promising results than single uncultivated cells. Thank you for highlighting this.
Thank you.
Yeah.
And I think we should also quickly mention the possibility of getting tissue from the inside the mouth as well. So that's COMET, cultured oral mucosal epithelial transplantation. And that, whilst it doesn't clear, at least is an autograft, so it doesn't require any immunosuppression, and that still provides navigational vision, which is good enough for some people who do not want to take the risk with keratoprosthesis. Because obviously with keratoprosthesis, even the OKP, it is inherently unstable, even though it's much more stable than the Boston K-Pro. And some people do not want to take that risk. Well, have a good evening, everybody, and thank you for including me. Now I'm going to go to the kitchen and see what dinner there is for me from Vivian.
Yeah, thank you for joining us. Thank you very much, Professor. Dr. Nancy, if you still have time, we can ask the questions of the audience. Yeah, answer the questions if you don't mind.
We can answer questions, yeah.
Yeah, please. What is the difference in the management of acid and alkali regarding vitamin C?
Actually, I do kick in vitamin C in any case of epithelial defect that I want rapid rehabilitation and epithelialization. The combination of vitamin C and doxycycline, which is an anticollagenase, and the steroid is very crucial and plays a significant role in promoting re-epithelialization. I do not make a difference between acid or alkali in that regard, and I do not make a difference between, and we're talking about oral vitamin C, by the way. We're not talking about ascorbic acid, and I think this is where the question stems from. So ascorbic acid is not in my choices or list of choices for the drops. I'm talking about systemic vitamin C orally, like 500 by 3, or sometimes you can go as 1000 by 3. It is safe and it's excreted in urine, so you cannot be panic about having a high dose. And if you kick it in with anticollagenase, it helps the stromal cells to and the epithelial cells to bridge the gap and defers melting. So it's very important to use. One of the very important points that I forgot to mention is the use of non-steroidal anti-inflammatory. There's a trend that's been seen recently between first-line encounters of chemical injuries that they're very afraid of using steroids, and instead they gave non-steroidal anti-inflammatory agents. And this is the most dangerous thing that you can do to a patient who has any corneal problem, because at that time you just transform him into an open cornea in no time. So please give steroids with caution, and never think of non-steroidal anti-inflammatory, no matter what the case is, because it will numb the eye and open it, and so the patient will be happily perforated, and that's the only thing.
Yeah, perfect. What is the effect of AMT in acute burn?
Acute chemical burn. As I said, amniotic membrane, it acts as a scaffold. It's an acellular matrix, and it has a lot of nutrients in it. So it just it helps the proliferation of cells. If the eye is very angry, and if it is still in the process of you want to assess and to treat, I wouldn't put it in the very early stages unless you know what's the extent of damage. There's a big damage that involves the epithelium and the whole of the cornea, and only topical drops will not do the job. You can use amniotic membrane as a scaffold to kick in or to boost the reepithelialization. There's also what we call Procera, which is a lens that can be fitted in the clinic that has an amniotic membrane, and you just put it as a contact lens on the eye. It's not available in all countries, but it just skips the need for going to the theater and just stitching or gluing the amniotic membrane. It's a choice. And but if the eye is angry and very inflamed, expect the amniotic membrane to dissolve as early as 1 week. What I prefer, in order to give the amniotic membrane the chance to work on the limbal stem cells and to give them the chance or the platform to proliferate, is when it stays on the eye as long as possible. And when we say as long as possible, means that the inflammation has subsided and we want to rehabilitate. So that's the best time, after 2-3 weeks, when everything is going quiet and going back to its track, and you put the amniotic membrane, it stays there for 2 to 3 weeks. The longer the better. The longer means that the inflammation is less, and it means that it's working more efficiently. So if you can put the AMT anytime. If you put it in an angry eye, you lose it so quickly, and you lose the benefit of its or the added value of it. If you put it on an eye that's rehabilitating, you will have it for long, and you will have an added value for your cells or the stem cells to rehabilitate.
Perfect. Thank you very much. Now, what's the difference between conjunctival limbal graft and keratolimbal? When we can use this one and that one?
For a cornea surgeon, a conjunctival limbal graft is a desperate measure. So if you have no access to a keratolimbal allograft, which is keratolimbus is a limbus with a sclera without a conjunctiva. It's limbal stem cells with the adjacent sclera and a little bit of the cornea, with the conjunctiva is pushed away, so you don't have conjunctival cells, and it's usually taken from a cadaveric cornea. The conjunctival graft, it's only a tissue to cover a defect, a thinning, a melting, and you use this if you're desperate, if there's nothing else to use and you want to close the eye. Now, what I don't like about the conjunctival graft is that once you put it there, you're just dooming the eye into permanent vascularization. So if you were thinking of rehabilitating the cornea with a transplanting a natural graft, then the chances of failure are very high, because you have invited the bear to your house. So you've put the vessels into where you don't want them to be. So unless the situation is rehabilitable, this is my own expression. So if it can be rehabilitated, defer from such. use whatever you have. A keratolimbar allograft, even if it fails, is better than a conjunctiva graft that has only squamous cells and vessels, and it only acts as a plug. It's a tissue plug for a cornea that's melting, and that's it.
Fantastic. Thank you very much. There is a question when we use the CLAU, CLAU, or KLAL.
As I said, the KLAL, CLAU, or the slit are the same. It's only slice. The slit differs is that slicing. We slice the limbal stem cells to give it a more area, surface area. So the tinier the slices are, you spread it all over the cornea, and you just give it a larger surface area to work on. When you put a circumferential keratolimbar allograft, it just encircles the cornea, and the only way for the cells to travel on the cornea is from the inside of the graft. While if you put a piece of slit, the limbal stem cells, they just travel from every side, and they just span the cornea in no time. That's the only reason, and the only difference.
Thank you. Now, how to preserve the amniotic membrane, the fresh amniotic membrane that we get from the newborns, okay? And how long can we keep it?
When we were short of fresh frozen amniotic membranes or dried amniotic membranes, we started to take it from cesarean sections, liaison with the gynecologist, and we know there's a planned elective cesarean section, of course, elective, because it will be prepared well and sterile environment, and we irrigate with antibiotics and carefully just remove all the debris around, and we take a very large piece of amniotic membrane and we put it in BSS saline with a little bit of whatever antibiotic is available, Fortem, Vigamox, and we preserve it in a jar or a box, and we cut out of it whenever we need it. Now it's important to know which side is it. The sticky side is the stroma, the glistening non-sticky side is the epithelium, because it's important to orient yourself where you're putting it, and it can be preserved in the fridge as long as a month, and we've been doing this for a long time now.
So for a month, we can keep it in the fridge for a month.
And you take it under sterile conditions. You cut of it under sterile conditions, of course.
Mm-hmm. Very interesting. Thank you very much. Is vitamin C beneficial for chronic epithelial defect in general, not only for chemical injuries?
This is it's not very clear, because what do you mean by chronic epithelial defect? Are we talking about non-healing epithelial defect?
Yes.
Or let's say a neurotrophic ulceration. Of course, vitamin C is crucial in boosting the re-epithelialization and activating the collagen build in the cornea. Not alone. Now we know that vitamin C is very important for the type 4 collagen, which is present in the stroma, and along with doxycycline, which helps stop the anticollagenases that are present in the stroma in cases of inflammation per se and infection, and steroid, which is an anti-inflammatory as well. So they all work together on the same arm to suppress inflammation, to boost collagen formation, and the vitamin C is very important in the cross-linking of the collagen fibers in the stroma. It's exactly as we do the cross-linking. So they help build up of the collagen fibers and the cross-linking of them. And so the collagen becomes, it decreases the melting, it decreases the inflammatory thinning, and it enhances the buildup of collagen. Now, why do we need the buildup of collagen while we're talking about an epithelial defect? The reason is that sometimes the epithelial defect does not close, not only because the edge is sick or it's not healthy, and we need to debride it in order to give a chance for the newer cells or the newer edge to close. The beneath it is a bowman and the stroma. Sometimes if the bowman and the stroma are not smooth enough or are not, they sometimes act as a dead bare area. And this dead barrier, it acts as a repellent for epithelial cells, so they just do not bridge the gap. What you need to do is rehabilitate the bed So the epithelial cells can just move on it and form desmosomal attachments and just sit there and close the gap. So this is how efficient vitamin C is. It's not for the epithelium per se, it's for the immune boosting and for the fixing of the bed of stroma that's causing the epithelium not to attach properly.
What is the dose of vitamin C that you give? 2 grams per day, for example?
The minimum I do is 500 milligrams 3 times daily. This is the minimum, but you can go as high as 3,000. You can give 1,000 3 times a day. And as I said, it's renal excreted, so it's not accumulated in the body, and you will not be worried, but lots of fluid to flush it away, lots of fluid. If a patient has a stone former, it's important to be lots of.
Yeah. Another question, if you don't have wet amniotic membrane, can you use a dry membrane?
Absolutely, yes.
Yeah, you mentioned that, yes, of course.
Yeah, you wet it and...
Now, I have a question. Regarding the wet one, do we need to do like tissue matching or suppression because it is not autologous? What do you think?
The membrane is only acellular matrix. It's a matrix that has no cells, it has no blood vessels, it's avascular, and it only has, you can consider it as a plasma. Do we need matching with plasma? No, we don't. So it's the same, we're not transplanting viable tissue. It's just a matrix with a nutritional content.
Now, when you use the wet amniotic membrane, do you need to suture it, or you can use a contact lens like the concept of the Procera or other? There are other brand names, of course, doing the same. So is it sufficient to put a large contact lens over the membrane, or we have to suture it?
If you want to lose it so easily, just put a contact lens. Yeah. So if you're okay to go into the hassle again, just put a contact lens because it's so easy. It's very fiddly. The amniotic membrane is very fiddly. It just can stick out of the eyelid. It just can be pulled out with a tissue paper. You can lose it so easily. So if you don't have a tissue glue, or if you don't have a conformer that tucks it under the eyelid and you close the eye, a contact lens will be a facilitator of loss rather than a preserver. You can just use 2 stitches on the corneal limbus, just 2 stitches to keep it just there, hanging there, and use a contact lens.
Fantastic. I think no more questions. Thank you very much, Dr. Nancy. We learned a lot. It was a fantastic lecture, as usual. Very, let's say, very dense. And I would like to thank as well Professor Lou for being with us and teaching us. And I want to say sorry for him because always the time of the lecture is just at the dinner time in the UK. So please forgive us for this. Thank you very much, actually. And I hope to see you in the next month with the coming lecture as well. Thank you, Professor Lou. Thank you, Dr. Nancy.
Thank you very much.
Thank you, everybody. Bye.
Dinner.
Goodbye. Good night.
Bye. Good night.